how active were your parents? Did your mother smoke? Does your mother smoke during pregnancy? Gestational diabetes, all of these things contribute so strongly. But when we're thinking about how to help our kids with obesity, increase that protein, increase that fiber. It's better nutritionally, but also it helps to kind of feel a little bit fuller as well.
With the BMI, my biggest complaint with that has always been that it's set to a particular standard of height, and not all genetics allow for that standard of height. An ideal weight is not just what your body says, it's also what the world around you says now.
Right.
And that can't be a goal we're trying to chase.
Right. And that's not 100%. What treating obesity means.
Yeah.
It's something that's chronic. It's something that you're going to have to work at it.
Today I'm joined by Dr. Jennifer Mulligan, who's already been on this podcast before. So if you haven't seen her first conversation, please go watch that before you see this one. This conversation too is about childhood obesity. We don't speak enough about it, but it's an extremely important conversation to have. So I'm so grateful that Dr. Mulligan took out some time from her busy schedule to come back and have a second conversation with us about this very important topic.
Hi, Dr. Mulligan. It's really exciting to have you back on this podcast. And I think the reason we're even doing a part 2 is because there's so much to talk about in the space of obesity, and especially pediatric obesity. I think I want to begin this whole conversation with talking more about that set point theory, which we had touched upon previously, but I think we can kind of take a deeper dive into it to understand what really it kind of comprises of the set point theory. What does it mean? What does it mean for kids who are trying to lose weight?
Yeah. Well, thank you so much for having me back. Last time I had such a good time. So the set point theory is like it exists. I don't know how much weight we truly put into it, but generally the idea of a set point theory is that your body naturally kind of has a weight that it gravitates towards, or a weight range that it gravitates towards, and it's dependent based on things like your genetics, like your personal history, family history, your medical history, and then environmental things too. Things like nutrition and activity and any medications that may be weight gaining. So it's basically kind of that multifactorial aspect of obesity, or just weight in general. And then people who struggle with obesity tend to have a higher level of kind of weight range that they may exist in, kind of based on this idea of set point theory, because of those genetic effects and because of those other environmental impacts. So all of this together kind of creates a certain level that your body and brain thinks that your weight needs to be at.
Okay.
And then within that idea of the set point theory, there's also a hypothesis of something called a Thrifty Gene Hypothesis, where it's that, your ancestors, you biologically may be prone to potentially keeping on more weight, because your ancestors historically may have benefited from storing energy during times of starvation, and then that helps them to be able to kind of keep those genes for their children and their grandchildren and so on and so forth. Yeah. I think particularly with the Thrifty Gene Hypothesis, there's not a lot of data to support that. And I think the idea of a set point theory is also very interesting, but as to how much data is actually behind it to support that, I think is still in question. But when we treat obesity, what's happening with the set point, or the idea of the set point, is that we're making adjustments to, environmental factors, not necessarily genetic factors, because we can't change that. But the modifiable aspects, we're adjusting to kind of lower that level of the set point, so that your body sort of recognizes that maybe it doesn't have to be at this higher level, it can be at a lower level and still kind of keep you alive, still, help you to survive. So that's kind of the idea of the set point theory.
Absolutely. And I was reading a little bit about this Thrifty Gene Hypothesis actually, because I think especially the South Asian population is one that's kind of, you can see the results almost of this Thrifty Gene Hypothesis, that yes, absolutely, there's not enough data to suggest it. Mm-hmm. But for example, South Asian women tend to store a little bit more fat around their hips as compared to Caucasian women. And primarily it's because of history of starvation, etc. And And now in the field of epigenetics, of course, we understand that if the parents, for example, include some kind of movement before they conceive a baby, there are certain patterns which do get changed for that future baby as well. So it's a pretty cool like evolutionary thing which happens.
Right. And I think within that too, you know, that really speaks to that multifactorial aspect of obesity. With childhood obesity particularly, we know that parent history matters a lot. Whether it actually truly has to do with like the DNA itself or the epigenetics or maybe a combination of everything, because obesity does tend to be so polygenic, it's hard to kind of parse out. But even having one parent with obesity or both parents with obesity significantly increases that child's risk of developing obesity. And then that prenatal factor and postnatal factor too has significant impacts. Things like how active were your parents? Did your mother smoke? Does your mother smoke during pregnancy? You know, gestational diabetes, all of these things contribute so strongly.
And then even if you were born preterm, because then the Barker hypothesis comes into play that you're like trying to, then you like, because you're born preterm, you need to store more fat. And then it's also like how fast you're putting on that weight. Does it go?
That trajectory.
Is there a spike? Is it a gradual rise? So it's so multifactorial. And I think that becomes difficult to piece out when we think about childhood obesity. Yeah.
And I think that's also kind of why, you know, like the set point theory is such a really interesting theory. But there is just so many other factors to consider too, that it's important to recognize that it's not as simple as just saying, well, this is what my body wants to be, and that's why I'm here.
Correct.
It's really a combination of many other factors too.
Yeah, 100%. And when you talk about the set point theory, you mentioned that the idea with obesity treatment is to get your body to almost understand this is your new set point. How do you do that? How do you help someone's body almost teach itself that this is now my ideal weight that I need?
Well, I think that's basically kind of like the general treatment of obesity is that, you know, there's the nutrition and exercise changes that we make, but you have this connection between the gut and the brain where you have hormones that are going, you know, that are communicating constantly between it. Leptin, you know, ghrelin, PYY, you know, all those things that we had kind of talked about before. And those things are very difficult to change just with nutrition and exercise. So that's kind of, you know, with certain levels of obesity, that's when we start to incorporate more of the medical, more of the surgical therapy, because these medical and surgical therapies are having a stronger impact in that communication between the gut and the brain to be able to kind of adjust it so that the homeostatic regulation of feeding that's happening in the hypothalamus is better adjusted to feel higher levels of appetite suppression, maybe higher levels of kind of craving suppression as well, compared to just nutrition and exercise. But fundamentally, we still incorporate those from a overall kind of improvement in health perspective, long term.
You just touched upon the gut and the brain connect, and I want to kind of piece that a little bit more to help the people who are listening understand what happens on a very like neuroscience level to make you feel hungry, to make you feel full, how your body decides that you're hungry, how your body decides that you're full.
Yeah. I mean, so I will say that it's so nuanced. There's so many different things happening at different levels that I don't know if I could, do it justice, but I'll try my best. So, when we think about obesity as a disease process, it's not just about, you know, the gut. It's not just about feeling hungry. There are hormones that exist in your GI system. That's kind of like the second largest sort of endocrine system that we have. And then you have hormones and you have, you know, these chemical signaling that's happening in your brain. And there are connections between the gut and the brain that regulate your levels of feeling hungry, your levels of feeling full, your levels of feeling satisfied with certain meals, certain things that you want to eat. And within the hypothalamus, a very specific part of your brain, there are these kind of neurons that talk to each other to regulate that level of fullness and hunger, just kind of at its like the simplest level of explaining it. But the way that it does that, the way that it regulates that is by talking to the gut all the time. So this is happening at a level where you're not even conscious of it. It's like 24/7 where they're constantly kind of in communication. But let's say that you eat something, you have dinner, your gut kind of recognizes that it has, food in its system, and then it sends signals to your brain to kind of let it know that we've eaten something. So then your brain should be able to then kind of trigger something to say, hey, okay, so the stomach says that we have food. And so now we don't have to feel as hungry anymore. So then it changes the levels of hunger hormones versus fullness hormones, the ratio between them, to allow you to then not feel as hungry. And then you can start to kind of, push away the plate if you're full. With obesity, that communication may not be working as effectively as someone who does not have obesity. So then that kind of level of feeling full may not happen as quickly or as readily as someone who doesn't have obesity. There are other body systems that also contribute to, for example, like fat tissues produce something called leptin, which is like your fullness hormone. And the fullness hormone is basically supposed to help you feel more, kind of like that, obviously make you not feel as hungry, makes you feel fuller, but it also kind of helps with satiety or kind of that feeling of satisfaction. And so all of these different organ systems in your body, your stomach, your GI system, your pancreas, your fat tissues, your brain, are all talking to each other constantly, regulating that kind of level of hunger, fullness, to sort of support the energy balance that you have. Because this is happening all the time and you don't have conscious control of it, that's why obesity is a disease process. Your body should just kind of naturally know how to regulate the weight based on all of this information that the body and the brain are sending to each other constantly. But when you have obesity, that sort of regulation isn't happening the same way that it does for someone who doesn't have obesity.
Absolutely. I think you did an amazing job of explaining what it is, because it's so complicated to piece out, and it's so complicated to really break apart and understand what's going on. I would say one of the most important things of changing these hunger cues that your body gives you is during childhood, for example, when you're overfed or when you're forced to eat. Mm-hmm. That's one of the biggest changings. Like that's one part which changes for a child when they stop recognizing their hunger and fullness cues.
Yeah.
Of course, it doesn't mean that you should let your child go when their plate is full and they just are throwing a tantrum and don't want to eat.
Yeah.
But it's also about recognizing that they might be full, so we shouldn't force them to eat more.
Right. And so that is an important piece. I will say it's also important to recognize that, eating more doesn't necessarily mean that you're going to develop obesity, right? But definitely if, your child struggles with obesity, stop forcing that kind of clean plate award sort of mindset, because it's not helping the situation. Yeah. And so definitely trying to help our kids kind of recognize a sort of fullness cue, and being able to kind of dictate when that happens is an important piece to this. Okay. And other things that will help with this too is the more protein that they have, the more fiber that they have, the more that the body needs in terms of like caloric intake and energy expenditure in order to kind of break all those things down. So when we're thinking about how to help our kids with obesity, increase that protein, increase that fiber. It's better nutritionally, but also it helps to kind of feel a little bit fuller as well. And it requires more energy from the body to break it down. So it's better from kind of like a metabolism standpoint.
Yeah. I couldn't agree more. And to steer us away into the direction of measuring obesity. Just before we started, we were talking about how BMI looks so different from ethnicity to ethnicity.
Yeah.
It can't be the gold standard measurement to understand where we fall in the spectrum. You use these measurements in your daily practice. I'm sure you might be using some other kind of measurements.
Right.
What do you rely most on? What should people take a look at first?
Yeah. So it differs a little bit when we look at adults and when we look at pediatric patients. Ultimately, BMI I think it's a great screening tool from like a population standpoint. It does give us good information. A lot of times it's fairly reliable, especially when we kind of look at more moderate to severe level obesity, BMIs that are higher higher than maybe 32, 35, 30, 40. But it's not everything, because the BMI, it's just a ratio of what your weight is compared to your height. It tells us nothing about the body composition, how much, your organs are contributing, how much muscle is contributing, how much fat is contributing to your overall weight. And so in adults, we use BMIs as screening tools, but we also have to consider things like waist circumference or waist to hip ratio or waist to height ratio, because these will also give us anthropometric measurements so that we can assess that in addition to the BMI to look at visceral fat, which is kind of that fat mass that has more metabolic consequences. In pediatric patients, we do sometimes use BMI. But more importantly, we use BMI percentiles because it gives us kind of a way to compare across like other kids of the same age and gender who, who either maybe at like a normal, underweight, overweight, have obesity kind of statuses. We don't commonly use Z-scores with pediatric obesity because it correlates actually negatively with age and more severe levels of obesity. So instead of Z-scores, the percentiles actually have been shown to be better correlated with the severity of obesity. So in kids, actually, that's still, I think, the primary way that we determine the level of obesity. But as of actually January this year, there was a new kind of commission that came out from the Lancet that suggested that with obesity, BMI is not enough, and we do have to have at least one anthropometric measurement in order to kind of clinically diagnose obesity. The AAP doesn't follow this recommendation. It still kind of uses that BMI percentile, but in adults, that's kind of the new recommendation. So the way that we practice at the Weight Center at Mass General is that we do still get the BMIs and we get BMI percentiles for our kids. We can do that with like a drop down that's a calculator that kind of does the work for us. But with adults, we also make sure to try to get that anthropometric measurement. I also get it in my kids, though. I don't think it's a bad idea to, because that's another way that we can measure kind of how they're improving over time, even if they may not necessarily be seeing a lot of weight changes. If we're encouraging them to also exercise and build muscle mass, and that contributes to weight, being able to kind of see that waist circumference difference is still very encouraging for them to see.
I couldn't agree more, because it's also always good to have a little bit more data than to just rely on one particular piece of data. And with the BMI, my biggest complaint with that has always been that it's set to a particular standard of height, and not all genetics allow for that standard of height.
Absolutely.
South Asians typically are shorter.
Yeah.
So when they're put onto the BMI scale, they're going to end up looking very bad, because they're just shorter. So anyway, that ratio is kind of a bit displaced. It's not a fair measurement in that sense.
And it's really kind of driven more towards Caucasian populations. And so as like an East Asian person myself, I completely agree. I don't think that the BMI from the WHO standards necessarily correlate to other populations. And I think a lot of other East Asian and Southeast Asian international societies, I think they would agree, because ultimately within kind of the Asia Pacific regions, there's a different standard for what qualifies as having overweight and obesity. In general, so the WHO says that overweight and obesity is a BMI of 25, and and obesity starts with a BMI of 30. But a lot of Asia Pacific international societies say that overweight starts at a BMI of 23 and obesity starts at a BMI of 25. And that's because the amount of visceral fat that's seen in these populations are higher compared to Caucasian populations. So even if we did have a lower weight, even if we did have, a shorter stature, that comparison of that BMI can still be at a lower level than maybe what the WHO would say. And we could still have higher levels of visceral fat, which then mean that we might have higher levels of metabolic dysfunction.
Absolutely. Just for everybody who is listening, I wanted to break about what visceral fat means. It's just the fat that surrounds the organs. And this kind of fat is more kind of detrimental in a metabolic like when we take a look at it from a metabolic standpoint, because this is the one which is linked to chronic disorders, things like heart diseases, etc.
Yeah, absolutely. Yeah, fatty liver disease, renal dysfunction, dyslipidemia, diabetes. It's the visceral fat that's been connected. I think subcutaneous fat still has certain levels of metabolic dysfunction associated with it, but higher levels of visceral fat definitely have been linked to metabolic dysfunction.
Right. So subcutaneous fat here is the fat under the skin.
Right.
And visceral fat is the fat around the organs.
Yes.
To make it very simple for everybody who's listening to understand this. As my final question for you, I wanted to understand more about the treatment options. Now, like Ozempic, GLPs are the absolute hype that there is right now.
Yeah.
People are really talking about these things because, of course, their results are proven. They're being seen. They're pretty magical drugs for those struggling with obesity. But what are some treatment options that you utilize at the weight center?
That's a great question. So we did definitely touch upon the GLPs, and I think they are great therapies. But cost is a huge barrier to these, and also just the supply and demand is a big issue. And so if and when maybe GLPs may not be appropriate, or they're not maybe just viable options for whatever reasons, some other common medications that pediatric patients have access to are things like phentermine topiramate, bupropion naltrexone, but there are age limitations to these, and we'll review that. And then metformin, or using maybe like phentermine or topiramate separately, are also options. So the first one that I mentioned, phentermine topiramate, that's a combination of two different medicines, phentermine and topiramate. Phentermine is a stimulant. It's technically considered a controlled substance because chemically it kind of acts like Adderall or Ritalin, which are stimulants that are used to treat attention deficit hyperactivity disorder. Phentermine is not used to treat ADHD, but it chemically kind of works that way. So it's classified sort of under that same umbrella. It has side effects that are kind of similar to stimulants, but ultimately, any of these medicines that I listed have that central impact in the brain to help with that appetite suppression by working in that hypothalamus to help with that regulation of feeding. So phentermine is one half of the phentermine topiramate combination. Topiramate, we actually use off-label to treat obesity. It's FDA approved as, from 2 years of age to treat migraines or to prevent seizures. But topiramate has also been shown to help with has some weight loss impact, especially in cases where there may be some weight gain from using second generation antipsychotic medications. Not only is it that topiramate has that impact, but metformin does well. So metformin is a medication that we use to treat prediabetes and diabetes in adults and kids. Generally, we don't use it before the age of 6, but in certain, you can use it off-label if necessary. And metformin has also been shown to help kind of mitigate some of that weight gain that you might experience from using second-generation antipsychotic medications too. So, and metformin is a really, really benign medication. It doesn't really interact with anything. Sometimes it causes a little bit of like GI upset, maybe like a little bit of like diarrhea or so, tends to go away with time. Topiramate does have a little bit more cognitive side effects just because of kind of the way that it's used and what it's used for. But these are definitely options that can be started much younger than maybe some of the other GLPs, where right now the FDA approval starts at 12 years old, although maybe that might be decreasing to 6 now with this new Step Young trial. The kind of other medication option to consider is bupropion naltrexone. That is really more for like the age of 16 and up. That's kind of where the FDA approval starts. So bupropion is an antidepressant, but it's also used to treat tobacco use disorder, and also has been shown to have some improvement in binge eating disorder as well. Naltrexone is used to treat chronic opioid use disorder as long as they're not currently using opioids. So people in remission. also used for alcohol use disorder. So one common theme with bupropion and naltrexone is that it has that impact in terms of kind of that reward pathway, that addiction pathway in the brain. And so this kind of combination might be really great in people who struggle a lot with like food cravings or food noise, because that same area of the brain that deals with addiction and reward is also where a lot of that kind of food noise comes from.
Yeah.
These medicines, the phentermine, topiramate, phentermine alone, topiramate alone, metformin, bupropion, naltrexone, they are not as effective from like an overall weight loss perspective in terms of percentage compared to these GLP therapies.
Okay.
But in a world where we don't have access maybe to GLPs kind of universally, there's still really good options to explore.
100%. And we didn't speak about this when we were talking about the neuroscience of hunger, but I think one important pathway is this reward system pathway, which deals with cravings, that kind of balance of salt and sweet, which again, food marketing agencies have really cracked, because that helps you get addicted to them, and that drives that whole reward system pathway and dopamine and that entire realm of
absolutely.
So, for sure. So there's another layer to even thinking about the neuroscience of hunger, where it's so driven just by the rewards of it as compared to even the hunger of it.
Yeah, absolutely. Thank you so much for clarifying that. Yeah, so it's not just the hypothalamus that's affected. It's other parts of the brain, the amygdala, that deal kind of like a lot with that sort of, craving and the satisfaction aspect. And then there's other parts of the brain too, the frontal cortex, the prefrontal cortex, that are all in communication.
Yeah.
So it's so hard sometimes to explain exactly what's happening with obesity, because it may be a little bit different for everyone. Kind of what areas are touched on more and what areas may be affected more may be different from person to person. So then we have to also kind of adjust treatment individually based on kind of what's going on.
Yeah. And another thing about all of these conversations that we've had regarding the medicines is that it has to be done upon discretion of a doctor who knows when to start them, when to stop them, how much to give. It can't be something that you demand, or it can't be something that you force upon, or you really try to seek out for yourself.
Yeah.
Because it has to be done, and especially when we're talking about kids, it has to be done so cautiously and so carefully.
Yeah, I think one of the challenging things about treating obesity is where do we say that it's enough?
Yeah.
Like, do we have to get to a normal BMI, quote unquote normal BMI, in order to be healthy? And so one thing that I always talk to my patients about is, yes, the number on the scale matters to an extent. If you have a BMI that's very, very high and the weight is very high, we obviously want to bring that down.
Right.
But I definitely don't talk about a goal weight, and I don't talk about an ideal weight for my patients, because I don't think that exists. I don't believe that there is any one particular number that you have to get to in order to be healthy. And so other things that we look at instead are, how is your physical function? If you have other chronic disease processes that may be affected by or affecting the obesity, how are these being improved as we treat as we lose weight, as we treat the obesity?
Yeah.
And if we're seeing that these other disease processes as well as the obesity is being treated, maybe the person has more, energy, they have better ability to be able to improve their physical function. All of these things should then kind of perpetuate an improved health. And so when we treat obesity, it's really about improving that overall health rather than trying to, get down to this particular number on the scale, because maybe that's where all my friends, are, or that's what social media tells me I should be at.
Exactly. Because an ideal weight is not just what your body says, it's also what the world around you says now.
Right.
And that can't be a goal we're trying to chase.
Right. And that's not 100%. What treating obesity means.
Yeah.
It's something that's chronic. It's something that you're going to have to work at it for the rest of your life. We can't ever truly eradicate it because it's chronic. Correct. It's not like treating pneumonia. It's not like treating a skin infection where we have an antibiotic and it just gets rid of it. This is something that you have to work at for forever. So then also the goal is going to change over time. where we may have needed it for, when someone is 6 years old, may change when they're 12, may change when they're 18, may change when they're 40, because life changes.
Absolutely. I think this is a very good kind of message to leave everybody who's listening with, that obesity, A, is lifelong. Your actions towards it also have to be lifelong.
Absolutely.
And your idea of it is going to change for the rest of your life. It can't be something that's set in stone. It can't be a weight that you're constantly trying to chase.
Yeah.
Nor can it be a mindset that you're constantly trying to chase. I think it has to be so malleable,
Yeah.
almost which grows with you as you grow up.
Yeah, absolutely. And that's why working with like a professional, like an obesity specialist is important. You want to get labs. You want to make sure that, if you do have other dysfunctions that show up on labs, that we're tracking it and that we have something objective that we can look at. And also you need someone to kind of be there to help kind of support you, but in a healthy way.
Yeah. Thank you so much, Dr. Mulligan. This was also just an incredible eye-opening conversation, which is, I think, so helpful. It's so helpful to hear from someone who specializes in this, who sees these cases day in, day out, to get a take from them firsthand without any of like the clouds of, just seeking information not otherwise on the internet would bring.
Well, thank you so much for having me. I really appreciate it.
Thank you.
I'm so grateful to Dr. Jennifer for giving us her time. And thank you so much for listening to this podcast.